decrease. Okay, so what happens? If there is any stressor or any inciting factors, the baby will first try to compensate. Okay, so rapidly breathe गर्छ, त्यसपछि primary apnea मा जान्छ, त्यसपछि irregular gasपहरु आउन थाल्छ, and then the child will go into secondary apnea. Secondary apnea ma what will happen? The heart rate and blood pressure will also decrease. Now during, if the child is in primary apnea, हामीले stimulate गर्यो भने, flickering movement हरु, back हरु rub गर्यो भने पनि baby will then again start to breathe. The secondary apnea ma, the tactile stimulation will not work. You have to give positive pressure ventilation in the form of bag and mask ventilation. Okay. Once the child develops secondary apnea, they will not be able to stimulate, even if you stimulate, they will not be able to regain the respiration. So you have to give respiration from the outside by means of positive pressure ventilation, that is by bag and mask ventilation. Now, this process can occur anytime in utero or during birth. So if a child is born with apnea, we always assume that the baby is in secondary apnea. Okay, so we do not waste the time giving tactile stimulation. Lamo time samma tactile stimulation ma time waste garne haina. Ekshima tactile stimulation ma, if the baby is not reverting back, we go directly to bag and mask ventilation. Okay, so always remember that. So bag and mask ventilation should be started in the first minute of the life if the baby is not breathing. So physiology ma ke cha, when the baby become asphyxiated, they develop rapid breathing, then they develop primary apnea, and primary apnea pachi alikati irregular gasping huncha, then after they develop secondary apnea. Now secondary apnea, we always assume baby is in secondary apnea. If the baby is delivered without breathing, we assume that the baby is in secondary apnea. So primary apnea is usually reverted back by tactile stimulation, but secondary apnea always requires bag and mask ventilation. So whenever the baby is delivered with apnea, we assume that the baby is in secondary apnea, and we do not waste time giving tactile stimulation for a long time. If the baby doesn't respond, we immediately start bag and mask ventilation. Okay, I am repeating this again and again because this is very important. The bag and mask ventilation or the first breathing should be given within first minute of life to prevent neurocognitive damage to the baby. You slide clear, Saki Saina? This is a very important slide. Is this slide clear?
Yes, ma'am.
Okay. So now, what is hypoxic ischemic encephalopathy? Okay, so hypoxic ischemic encephalopathy, this is the main part that we'll be discussing, refers to a characteristic neurological manifestation in the babies which develops soon after birth following perinatal asphyxia. So after perinatal asphyxia, if there is a problem, if there is a neurological manifestation, that is known as hypoxic ischemic encephalopathy. So it is encephalopathy developed due to hypoxia or birth asphyxia, and it develops soon after birth. So what happens is same, there is a lack of adequate breathing, so lack of oxygen supply to the heart, and heart pumps inadequate blood, and all the organs, especially the brain, is affected. And before we go on to the hypoxic ischemic encephalopathy, you should know about diving reflex. So what happens in diving reflex is always what happens is whenever there is asphyxia or whenever there is decreased amount of oxygen in the surrounding, the blood will send to the vital organs like brain, heart, and adrenals away from the, so lungs, gut, kidney, liver, spleen, and skin will have received less amount of blood supply. So all the blood will be shunted to the vital organs. So this is known as diving reflex. So initially, the blood supply will try to protect this brain, heart, and adrenals. And these other organs will receive less amount of blood. But if the asphyxia keeps on continuing, if the oxygen is still in the lower amount, then these organs will also be affected. Most of the time, if the baby has severe birth asphyxia, all of the organs will be affected because all of the organ will receive less amount of oxygen. That is why the baby will develop multi-organ dysfunction. Now, what are the predisposing factors? We talked about earlier that every baby can potentially develop birth asphyxia, okay? But there are certain conditions, certain predisposing factor that you should be aware of. If you know that this baby has these kind of predisposing factors, you have to be better prepared during neonatal resuscitation, and you should properly monitor these kind of babies. So maternal condition, if the mother has medical condition like hypertension, diabetes, gestational diabetes mellitus, mother has infection like any kind of infection, UTIs, chorioamnitis, if the mother has some earlier cardiac disease, if the mother has history of, if there is uterine rupture during labor, these are the conditions that can cause birth asphyxia. Now, placental cause, abruptio placenta. If the placenta separates prematurely, prolapsed cord, if the cord comes out before the baby, and if there is some malposition like breech delivery, transverse lie, then the baby has more chances of developing birth asphyxia. Now, in case of fetal causes, if there is multiple pregnancy, twin pregnancies, or second baby have more chances of developing birth asphyxia. If the baby is very big with cephalopelvic disproportion, then the baby can be stuck, obstructed labor, then after the baby can develop birth asphyxia. If the baby has some fetal anomalies, like hydrocephalus, anencephaly, some fetal anomalies, this can also precipitate birth asphyxia. And if the baby has pars meconium inside the utero, the baby also can develop birth asphyxia. These are some predisposing factors, okay? So if the baby has these kind of predisposing factor, if the mother has these kind of predisposing factor, you have to be prepared for tackling the birth asphyxia. Now, hypoxic ischemic encephalopathy can be staged in the 3 stages. So there are 2 staging. One is Sarnath staging, Sarnath and Sarnath stages. Another is Levin staging. They are almost same. So Sarnath and Sarnath staging, hypoxic ischemic encephalopathy is divided into 3 grades. Grade 1 is mild, grade 2 is moderate, and grade 3 is severe. So what happens in grade 1? In grade 1, if the baby baby did not cry immediately after birth, you did their neonatal resuscitation and you keep the baby in the NICU, and then you watch out for HIE, signs of HIE. So 24, 48, 72 hours, you have to keep the baby under close observation. Okay, baby birth asphyxia boyo, then you did bag and marks ventilation and baby cried when mommy side you have to keep the child in NICU to watch out for the signs of HIE. Initially mild this mild HIE can progress to moderate and even severe HIE. So at least 72 hours this baby should be observed closely in the NICU. So what happens initially in grade 1 HIE, the baby will be very hyper alert. Cry gare, ko gare, ekdamai irritable. Muscle tone will be normal or increased. There will not be any seizure in grade 1. And respiration will be regular. So if you have to remember a point about grade 1 HIE, remember that the child is very, very irritable in this type. Irritable Moro's reflex when exaggerated tone or increase. Okay? And in grade 2, the child starts to become lethargic and then the child will develop seizure. So grade 2, if you forget everything, just remember, once the child develops seizures, once the baby develops seizures, then the baby has gone into grade 2 HIE. And grade 3, baby will become comatose, ekdam drowsy, comatose, respiration apnea, and most likely will go into mechanical ventilator. Okay? Even if you don't remember anything, just remember this. Grade 1, the child will be very, very irritable, hyper alert. Grade 2, the child will develop seizure. Grade 3, the child will be comatose. Okay, so this is Sarnath staging of HIE. Levin staging is also same. Levin staging consciousness irritable, then the child will develop seizure and the child will become comatose. So Levin ko lai paddaina, you have to remember Sarnath staging of HIE. Now, along with the hypoxic ischemic encephalopathy, the baby will also develop multi-organ dysfunction because all the organs will have ischemia and they will be receiving less amount of the blood. Okay, so ultimately what happens? The baby can develop renal abnormality. The baby will go on to develop oliguria, acute tubular necrosis, and then acute renal failure because the kidney will be receiving less amount of the blood. And CNS, we have already talked about HIE, and sometimes the baby can also develop intraventricular bleeding. In cardiovascular abnormality, if the heart is receiving less amount of the blood, then there will be ventricular failure, right heart failure mode and left heart failure. The baby will develop tricuspid regurgitation and hypotension and shock Mazansa. Okay, and in case of lungs, the baby will develop persistent pulmonary hypertension and pulmonary hemorrhage. In gut abnormality, the baby will develop ischemia and ultimately leading to necrotizing enterocolitis. And in blood abnormalities, the baby will develop thrombocytopenia and bleeding disorders because of coagulopathies. So these are the multi-organ dysfunction that the baby can develop after birth asphyxia. Now, how do you prevent birth asphyxia? These are the methods of prevention of birth asphyxia, because as we talked about earlier, birth asphyxia is the second most common cause of neonatal mortality and morbidity. Okay, so if you prevent that, we can prevent lots of newborn deaths. So how do you prevent it? Number one, we ask the mother to have a regular antenatal checkup. Regular antenatal checkup purpose ke huncha, abnormality can be detected earlier. Hypertension, maternal diseases, if fetal abnormality cha ki chaina, these can be detected earlier, and so we can manage accordingly. Number two, anticipation of complication during labor. So we should always know about the predisposing factor. So we can anticipate the complication during labor, so we can adequately prepare for neonatal resuscitation. Okay. Timely intervention. This is the golden rule. So if you can tackle the birth asphyxia within the first minutes of life, first few minutes of the life, properly tackle garna sakyo bhane, we can delay and we can prevent neurological outcomes. Okay, so the idea is the golden minute. So first minute of the life, the baby should have taken the first breath, either spontaneously or via bag and marks ventilation. So this timely intervention is very, very important. And management of maternal complication. If we can manage maternal complication properly, we can also prevent birth asphyxia. And the baby delivery should be coordinated by pediatrician, or if pediatrician is absent, any health personnel who is trained in the neonatal resuscitation. Okay, so this is how we prevent birth asphyxia. Now, what are the investigations that we send? Usually, there aren't any confirmatory lab tests to diagnose perinatal asphyxia. The investigation that we send are basically to find out the complications and find out whether multi-organ involvement cha ki chaina bhanera find out garnako लागि. Okay. Number one is septic screen. You people had your class in neonatal sepsis. Did you have class on neonatal sepsis?
Yes, ma'am.
Okay, so you know what septic screening is. So basically we send for septic screening to rule out infection. Then we send for arterial blood gas, ABG. This is to find out the extent of hypoxia or extent of hypoxemia. Blood ma oxygen kati kam cha, carbon dioxide ko kati badi cha, metabolic acidosis, lactic acidosis, anaerobic respiration or body bara lactic acidosis badeko cha ki chaina. So these can be found out by using arterial blood gas. Then we check for whether organer involvement bhako cha ki chaina. For renal function test, we send for serum urea, creatinine, sodium and potassium. And we also send for calcium and magnesium, because calcium and magnesium will also be, metabolism will be also be affected in birth asphyxia. Then we send for liver function tests. We send for coagulation profile like PT and APTT. We send for blood sugar, cardiac profile like CPK, MB, USG cranium to see whether brain intraventricular bleeds bhako cha ki chaina, MRI brain to see the extent of the brain involvement, and EEG to find out whether the child is having seizure or not. Okay, so these are the investigation that we send. Now, what are the principles of management? How do you manage birth asphyxia? The principle of management, first is neonatal resuscitation. Proper neonatal resuscitation is key for management of birth asphyxia. Then after, if the child has already developed birth asphyxia, supportive therapy, anticonvulsant to prevent seizure, there are some neurocognitive intervention and proper monitoring. These are the key principles of management. The first one is neonatal resuscitations. Now, you'll have a separate class in neonatal resuscitation, and you'll have a basic training in the basic neonatal resuscitation when we are in the final year. Okay, so I'll just be talking about briefly for neonatal resuscitation. So neonatal resuscitation ma ke huncha, baby janmine bittikai, this is the inverted pyramid of resuscitation. So you have basic resuscitation mechanism and you have advanced resuscitation mechanism. All the MBBS graduates should be trained with the basic newborn resuscitation. Okay, so basic is once the child is delivered, so we go for drying, warming, positioning, suctioning, and tactile stimulation. And tactile stimulation, if the child is not crying, we do not waste time on tactile stimulation, and then we go directly to bag and marks ventilation. And if the heart rate is less than 60, we start chest compression. And if the child is still not breathing, then we go for intubation and medication like adrenaline. So look at this inverted pyramid. Intubation and medication, we rarely require. Even chest compression, we rarely require. Most of the time, the baby is reverted back due to proper bag and marks ventilation. And this is the bag and marks ventilation. And everybody should be trained. All the health personnel, not just doctors, nurses, trained birth attendants, everybody should be trained to deliver effective bag and marks ventilation. Because with just this effective bag and marks ventilation, we can prevent lots of cases of birth asphyxia and lots of cases of HIE. Okay, so this is proper newborn resuscitation, number one method. Number two is supportive therapy. We take care of the oxygenation and we make sure that we do not want hyperoxia. If hyperoxia occurs, what happens is free radicals are generated and that causes more harm to the brain. So oxygenation is maintained. We keep on checking with the ABG. ABG ma hyperoxemia bhayo bhane, we decrease the oxygen content. Number two, avoid hyperthermia. Increased temperature also damages the brain. So we avoid hyperthermia. Then judicious fluid management. We make sure that we are not giving extra amount of fluid, because extra fluid cerebral edema develop garcha, so that will again precipitate HIE. So we give only 2/3 of the maintenance dose. And we strictly monitor blood sugar, urine output, and serum electrolytes, because hypoglycemia and hyperglycemia both can cause damage to the brain. And urine output, because we do not want the child to go into renal failure. Okay, so and then the child may need ionotrope support like dopamine, dovitamin, adrenaline. And because there is decrease in the calcium level, we have to give calcium supplementation. And another mainstay of treatment of birth asphyxia is we need to control the seizure, because second stage of HIE jane bittike, the child will start to develop seizures. And how is seizure prevented? We can give anticonvulsant medicine like lorazepam, phenytoin, phenobarbital, and levetiracetam. Okay, so the supportive management is make sure we are not giving excess oxygen, make sure we are not increasing the temperature of the child. The child's temperature should be in the neutral temperature. There is a judicious fluid management. We do not want to overtreat the child with lots of fluid, so we are giving only 2/3 maintenance of the fluid, because we do not want the child to have a cerebral edema. And we strictly monitor blood sugar, urine output, and serum electrolytes, ionotrope support, calcium supplementation, and anticonvulsant like lorazepam, phenytoin, phenobarbital, and levetiracetam. Now, this one is a relatively new modality of treatment of birth asphyxia. This is known as therapeutic hypothermia. Okay, so not all hospitals in Kathmandu or Nepal have this facility. I think only Dhulikhel has this facility right now. So this is therapeutic hypothermia. What happens is we selectively cool the child or selectively decrease the temperature of the child. So ekdamai hypothermia ma pani haina, neutral temperature ma lane, so that the child is not severely increased temperature pani chaina ra dherai low hypothermia pani chaina bhanera controlled temperature hypothermia ma jane. This is therapeutic hypothermia, and then this is selective head cooling. So in case of therapeutic hypothermia, The child is put on a machine where the temperature is maintained in a neutral temperature, slightly decreased. We know that normal body temperature of a newborn is 36.5 to 37.5. So the temperature maintained, ekdam hypothermia pani haina, 35, 36 ma temperature maintained garcha. So what does this prevent? This prevents a harmful effect of the free radicals on the brain, and this will decrease the incidence of hypoxic ischemic encephalopathy. So this is the blanket which controls the temperature of the baby. So this is whole body ko therapeutic hypothermia maho, and this is selectively cooling of the head. So you have a helmet like this that decreases the temperature of the head. So this is the newer modality of treatment of HIE, which is known as therapeutic hypothermia. Now, what is the mortality incidence? If there is a moderate encephalopathy, the mortality incidence is 10 to 30%. But if the child has severe encephalopathy, mortality incidence is 60%. And this child will have some form of disability. 100% this child will have some form of disability. So, mortality sangsangai morbidity is also very important. Birth asphyxia morbidity incidence is also very, very important. So what is the long-term sequelae? If the child has birth asphyxia, so what can happen? If the child survives birth asphyxia, so long-term, what can happen? The child can develop developmental delay, cerebral palsy, microcephaly. The child can have seizures, multiple episodes of seizure. Later on in life, the child can be blind, deaf, or there may be problem with cognition, memory, fine motor skills, and behavior. See, so you can have a devastating long-term sequelae if the child has birth asphyxia. Even if the child survives birth asphyxia, he or she can have long-term sequelae later on in life. So what are the predictors of the poor outcome? So how do you know this child will have poor outcome? So if there is a failure to establish respiration by 5 minutes, so 5-minute Apgar score 3 or less. So 5-minute Apgar score is very, very important. This is after you have started resuscitating. Resuscitation vapachi pani Apgar score 3 नै भइराख्यो भने, that is a very bad prognosis. So seizure आयो भने, refractory seizure which cannot be controlled easily. So if the child is not able to feed orally, EEG, MRI, USG cranium abnormal, these are the poor predictors of HIE. Okay. So this is all about HIE. So HIE could see the mortality pattern, long-term sequelae. That is why you should always be able to prevent birth asphyxia. How can we prevent birth asphyxia? First, we should know the predisposing factors. So maternal history properly linu paryo. So predisposing factor antenatal line properly history linu paryo. Then after, if we can anticipate the complication, we can manage accordingly. And the very important part of preventing birth asphyxia is proper neonatal resuscitation. So if you are trained in neonatal resuscitation, if you properly resuscitate the child, this can be prevented. And after birth asphyxia bhayisakepachi, what happens is we can always go for supportive treatment, seizures, anti-seizure medication, and therapeutic hypothermia. Okay, this is all about birth asphyxia. Any questions? I think we are in the last minute. Do you want me to rejoin for 5 minutes if you have any questions? Any questions, Babu? China. So I think I'll stop my class then. Okay.
Okay, ma'am.
Thank you, ma'am.
Okay.
Thank you, ma'am.
So final year, you will be trained in neonatal resuscitation. Okay, that is a very important part as well.